home quarantine, and today I would like to talk about a quick guide to ophthalmic ultrasound, that is B scan interpretation. So this is my first presentation on webinar, so it's very difficult for me that you are getting or not. So if anybody has any query or any doubt or any comments, please put it on chat box, or you can call me after the session. So this is the base scan machine. So before going to the interpretation, we should know about the some terminology. So we all know about the audible range, that is 20,000 hertz, and more than 20,000 hertz is called ultrasound. Now, pulse ecosystem is a piezoelectric transducer to generate ultrasonic wave, a receiver which processes returning waves and display in screen. Similarly, acoustic impedance is the difference between strength of returning echoes from the different tissues. Angle of incidence is the angle of sound beam relative to area of interest. Resolution is the ability to distinguish between adjacent echo, both axial and lateral. Amplification is the signal processing before echoes, which is display on monitor, and gain is the process of increasing or decreasing amplitude of echoes, which are display on screen. And TCG, time gain compensation, is nothing. This is for the reducing the artifacts. So this is the technique used to enhance returning echoes from the deferred tissue by reducing those echoes, those structure closer to the surface. So now come to the principle of B scan. So principle of B scan is not very difficult. It is just I have modified it. Electrical energy is converted into sound energy with the help of piezoelectric crystal, and now sound goes to the different parts of the eyeball, and it is and come back in the form of echoes, and these echoes, with the help of again piezoelectric crystal, is converted into electrical energy, which is displayed in the monitor. So in case of abdominal ultrasound, 1 to 2 megahertz is used. In case of ophthalmic ultrasound, 8 to 12 megahertz is used. To UVM, 35 to 100 megahertz is used. So the relationship between the frequency and penetration and resolution is that frequency is inversely proportional to the penetration and directly proportional to the resolution. This means that if we have to see the anterior structure, then we have to take high frequency. We have to take high frequency for the resolution. Suppose we can see. Suppose we have to do UVM for the anterior segment of anterior segment, such as iris. Then we have to increase the frequency. Increase the frequency so that we can get better resolution.
Hello?
So indications of ocular B scan in case of media opacities are corneal opacity, anterior chamber hyphema or hypomine, meiosis, pupillary membrane, cataract, vitreous hemorrhage. In case of clear media, it is indicated in iris lesion, ciliary body lesions, tumor and masses for detection and differentiation, to differentiate different types of RD, intraocular foreign body detection and localization, optic disc abnormalities. Though B scan for orbit is not very much suitable, however, it gives a gross idea about the orbital pathology. So indication of orbital B scans are enophthalmos, globe displacement, lead abnormalities, palpable or visible mass, motility disturbance, pain, chemosis. So techniques, what are the techniques for the B scan is we cannot diagnose by looking the findings of this scan. So it's a clinical correlation with the findings of which we can see from the slit lamp. So this is the clinical correlation. So now there are three types of scan in case of ocular scan: that transverse scan, longitudinal scan, and axial scans. Transverse scan, probe is placed on sclera. In longitudinal scan, probe is placed at limbus. In axial scan, probe is placed on cornea. So in transverse scan, suppose we have to see the superior quadrant, then we have to place the probe inferiorly. That is, we have to place the probe at opposite side to the area of interest, and always mark lamps nasally while screening superior and inferior, and superiorly for nasal and temporal quadrant. So before going to normal, we should know about how a normal looks like. So first of all, coming to the lens. So lens is visualized by immersion technique or stand-off technique. So it is very simple. We can just make a water-filled balloon by cutting a gloves and fill the water or gel, and you can do you can put it on the eye, and you can do the scan. So crystalline lens, if there is clear, then there is no echo. That is echo-free. Clear lens is echo-free, and its intralesional echoes depending upon the cataract. And vitreous is echo-free, and depending upon the amount of vitreous degeneration, its reflectivity changes from low to medium. Until or unless there is a pathological condition, choroid, sclera, and retina is a single layer. So optic nerve, we can see here, optic nerve is wedge-shaped acoustic vial in the retrobulbar region. Similarly, ocular scans, there are two probe placement in orbital scan. One is transocular, other is paraocular scan. So in transocular scan, probe is placed within the muscular cone, and it is used to see the lesions of mid and posterior orbit. In paraocular, probe is placed beyond the muscular cone, just like you can see here. A probe is placed beyond the muscular cone, and it is used to visualize the lesions of anterior orbit and lids. So just like a transverse scan, transocular is in transocular, probe is placed at the opposite side to the area of interest. Suppose there is pathology. There is pathology in the superior quadrant. We have to place the probe inferiorly. But in paraocular scan, probe is placed at the same side to the area of interest. Suppose somebody has mass or lid abscess in the upper lid, then we have to place the probe at the upper lid only, not in the lower lid. So this is the basic difference between the transocular and paraocular scan. Extraocular muscles are best evaluated by transverse and longitudinal scans. Extraocular muscles are equivalent to low reflective fusiform structure. We know the superior rectus and lateral pubis complex thickness, inferior is thinnest, and because of its coarse and very small in structure, inferior orbit is not imaged except in pathological condition. And for the extraocular muscle measurement, we should take log gain, and we have to measure the distance where it is maximum. So to describe lesions, there are certain things should be kept in mind. That is location, extension, dimension, shape and configuration, internal reflectivity, structure, and mobility. So location with respect to easily demonstrable landmark. Suppose lesion is there, so we have to locate where the lesion is there. Is it inferior to the optic disc or superior to the optic disc? Whether it is nasal to the disc, whether it is um, temporal to the disc. So it is, or we can compare the lesion with respect to the lens also. So up to how much, or
Hello, sir. Excuse me, sir. Sir, I guess
yes.
yes, sir. I guess your sound is so cracking and sometimes muted. I don't know why. So since this presentation we are not able to understand you. Can you please repeat this slide once again, sir?
This is description on this. Okay.
Yes, yes,
Okay.
yes, sir.
So to describe a lesion, certain things should be kept in mind. Okay. So suppose there is a lesion. So there is a lesion where the lesion is present, where the lesion is located. So we have to compare. We have to compare to the demonstrable landmark. Suppose optic disc or lens. So whether lesion is superior to the disc or inferior to the disc, or it is temporal to the disc, like that. And Kapil, are you hearing me? Are you getting me?
Yes, yes, sir. It's so clear, sir. Yes, yes.
Okay. Okay. And for extension, where it is up to how much, how deeper the lesion goes to, whether it is anterior, posterior, or lateral. And in case of tumor and surgery lesions, we have to measure the dimension, and we have to look the shape and configuration of lesions, whether it is point like or membrane like or mass like. So it will be very easy to describe the echoes. So in internal reflectivity, whether it is equilucent, low, moderate, or high, and we all know sclera is 100% reflectivity. So internal reflectivity is compared with the sclera. And whether the lesion is solid or cystic, regular or irregular. And to differentiate, we have to do a kinetic scan for the mobility. So sometimes it's we get confused to recognize lesions because of imaging artifacts. Actually, there is no pathology, but it looks like something wrong in the scan. So these are as follows: the reverse artifacts. So artifacts happens due to the insufficient gel between eye and probe. Suppose there is a air gap. Suppose if there is air gap between the probe and eye, then there will be artifact. There will be there will come some artifacts. So in first picture we can see the silicon wire reverberation. And the second picture, if there is insufficient gel, or we do not use the gel, that time we can see this type of image. And sometimes we get confused whether this is intraocular foreign body, because here there is shadowing. So actually this is the reverberation of the lens. So this is artifact, and this is the case of dropped IOL. Similarly, in the visual reverberation also. Sometimes if there is some foreign body or air in the anterior chamber, and sometimes the suture after the penetrating trauma, after the OGI repair, then that time we can see the shadowing. So this is shadowing, this is nothing due to the artifact. So now in this vector, when probe is placed perpendicular to the surface, then a high reflective lesions noted at the macular area. So we often mistaken with whether it is foreign body or a scar. So to differentiate it from intraocular foreign body or a scar, we have to do scan for other eye also. In other eye, if if the lesion at the same side site, then we have to do we have to tilt the probe. We have to tilt the probe slightly, and if lesion is shift, that means this is the artifact. We can see here in the upper picture there is a lesion at the macula, and in the below other eyes, for the other fellow eyes, lesion at the macula. But when we are shifting the probe, then it moves to the superior nasal to the disc. So in this case we can see lesion at macula, and now it is shifted to the superior nasal, and we all know macula is inferior temporal, so it is not a lesion, it is a artifact. So this is the pictures, different pictures of same eyes taken at different gain setting. So to differentiate vitreous hemorrhage, we have to increase the gain, and we can get in case of vitreous hemorrhage, if there is vitreous hemorrhage is fresh, then low reflective dot line, multiple dot line echoes noted in the vitreous cavity. But if vitreous hemorrhage is old, then we can see relatively high reflective echoes in the vitreous cavity. Similarly, in subhaloid hemorrhage, you can see here low reflective echoes, band like low reflective echoes, just anterior to the pole, and we can do a scan in both supine and erect position also. So if there is subhaloid hemorrhage or vitreous hemorrhage, if you do a scan in inferior quadrant or in erect position, echoes moves downward. So this is the technique you can use in to differentiate whether it is vitreous hemorrhage or something else. Now vitreous schisis, this is nothing but so this is the splitting of membrane of vitreous. So we can found double or triple membrane in case of vitreous schisis. Sometimes we found in a scan there is multiple dot like echoes in the vitreous cavity without any causes, without any history. So that time we have to find whether tear is there or not. So if there is a tear, then a small band like high reflective echoes can be seen in the surface. So again, this is the pictures of same eye taken in a different angle. So in the first picture, we can see there is a high reflective funnel left echoes attached with disc. In the second picture, you can see slightly less reflective and attached with disc, but here we can see the configuration of the funnel shape is changed. Here thickness is slightly less than upper one, and in the third one you can see there is no disc attachment. So in PPD there may be funnel shape structure may or may not attach with disc, and its thickness is variable in different probe position, and while doing kinetic scans, and then there is free after movement. Sometimes we found vitreous as with dome shape elevations have hello.
Yes, Amit sir. Yes, yes, sir. You are
Okay,
audible. Okay.
okay. So sometimes you get vitreous hemorrhage with dome shape elevation at the macula. So this is actually due to the polyfoidal choroidal vasculopathy. So this is nothing the hemorrhagic PD. So this type of case we can see in the elderly patient. We can say what in case of wet AMD we can find this type of finding. So for that we have to check shall I also whether drusen is present or not. Uh, I have already told this is not for confirmation of I. Hello.
Yes, 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 sir. I guess your voice is sometimes cracking, sir. I don't know why.
Yeah, yeah. I don't know why it's getting. Okay, so now it's clear. Is it clear?
Yes, sir. It's
Am I
now a little
audible,
bit.
Kapil?
Yeah, yes, yeah,
Okay.
yes, sir. Yes,
So
yes.
so with the help of B scan, we can differentiate different types of retinal detachment. So it's very simple to differentiate the types of retinal detachment with the help of B scan. So in retinal in case of dermatogenous and exudative RD, there is convex elevation. But in case of tractional, there is a concave elevation. So and in retinal detachment, retinal detachment of genus type, there is presence of some breaks or giant retinal tears. And in exudative RD, in both the RD, exudative and dermatogenous, we can see funnel-shaped membranic echoes attached with disc. So so how to differentiate it? So first we have to do a scan in both position. First in supine position and second is erect position. If there is shifting of fluid, if there is shifting of fluid in postural change or shifting of fluid by pressing with finger, then it is exudative type. So we can see here there is a funnel shaped membrane goes attached to disc, and we can see there is a band like trot, and forming a second leg. So this is nothing. This is nothing. The RD is going to world. So you can say this is called PBR change, proliferative vitreoretinopathy. So if the shape of RD becomes close funnel like, then it is a old RD. And in case of old RD, we found there is a cyst-like structure. So in case of RRD, if there is a presence of folded membrane, then we have to suspect there is a giant retinal tear. Now coming to the retinal detachment and PVD. How to differentiate? First of all, in the both the cases, uh, high reflective, or sometimes medium to high reflective membranic goes attached with disc. Okay, so in PVD, there is high reflective membrane, funnel shaped high reflective membrane may or may not and in
Excuse me, sir. I guess you are muted. Excuse me, sir.
Sorry.
Yes, yes, it's audible. Yes. Sir, it's not audible. Still. For the moment, sir, we can turn on the desktop audio mode, sir. If mobile is not working, we can go through the desktop.
Kapil,
Yes, yes, sir. Yes, it's not clear. Yeah.
એટલે ધોકા દઈ રહ્યા છે.
But yes, sir. Sir, this is not audible now, sir. It's not audible. Yes, sir. Now, yes. No, 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 sir. No. I guess the system have the problem, sir. Can you please switch on with your desktop? Leave the phone and we can start with the desktop. Okay. Can you please increase your volume? Okay, you have to unmute yourself and increase the volume. I guess it will be a better if we switch off your video.
Kapil,
Yes, yes, sir. Now it's clear, sir. If you on your video, the system will be getting. Yes, yes, sir. It's audible. Can you hear me? Yes, yes, sir.
hello,
Audible. Yes, sir. Yes, yes, sir. You are audible. Can you please increase your volume?
Kapil, am I audible?
Yes, yes, sir. Yes, sir. Yes, you are audible, but you have to
Hello,
increase your volume in your. Yes, yes, sir. Yes. Just.
Yes, sir. Yes.
hello.
Yes, sir. You are audible, but can you please increase your volume on your
Hello.
laptop? Yes, sir. Yes. Increase. Yeah. Increase. Just.
Use
You have to
marks.
increase your volume. Yes. You have to increase your volume, sir.
Okay, 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 okay. No. Okay,
Yes.
Kapil,
Yes, yes, sir. Yes,
Kapil.
I can hear you.
Okay.
Yes, yes, sir.
So,
Yeah.
in RD, uh, in RD, funnel shaped membranic echoes attached at the center of optic nerve edge. But in PVD, there may or may not be attachment to the optic nerve head, and it the it may be in the peripheral parts of optic nerve head also. So and when we co- when we take a scan for in different scan, then there will be variable thickening in the membrane. And if we do kinetic scan, there is free after movement in case of PVD and restricted after movement in case of RD. So and if we lower the gain, then sometimes PVD disappear. So we can see here there are typical sign of corridor detachment, that is kissing sign, and we can see this type of images in case of traumatic choroidal hemorrhage following the intraocular surgery. So this is the expulsive. Now coming to the retinoschisis and negative RDs or PD or choroidal detachment. First, I would like to compare retinoschisis with the choroidal detachment. So in the both the cases there is dome shape elevation, but in case of retinoschisis, there is 100% reflective spike just anterior to the retina. But in case of choroidal detachment, there is 100% reflective spike, but it is double peak, that is M-shaped spike in the choroidal detachment. And now coming to the executive RD and CD. So in executive RD there is a funnel shape, and in case of choroid there is dome shape, and there is a kissing sign is present in choroidal detachment. And now what is the difference between retinoschisis and executive RD? So to differentiate it, we have to press the eye with the finger. If fluid decreases or changes in size, then it is exudative RD, and if it remains same, there is no structural changes by pressing with the finger, then it is retinoschisis. Coming to the trauma, so we can see here, this is in case of intraocular foreign body, there is 100% high reflective echoes with back shadowing. So we can see here in the first picture, intraocular foreign body inside the lens. So this image is taken by the immersion technique. And in second page, intraocular foreign body as retinal surface. In third picture, there is intraocular foreign body within the optic nerve, and the intraocular foreign body within the anterior vitreous. So now coming to the infections. So endophthalmitis, how to differentiate endophthalmitis to the Vogt-Koyangi Haradat syndrome. So in endophthalmitis generally unilateral, and there is history of surgery or trauma. There may or may not be present, PBD may or may not be present, and there is presence of vitreous cells. But in case of VKS syndrome, the case is bilateral and serous RD is present and no PBD is there, and few vitreous opacity is there. But sometimes in endophthalmitis, PBD causes the fractional RD. Now coming to the panophthalmitis. So in the both the cases there is presence of T sign. So in case of panophthalmitis, there is marked thickening of ocular cords, and in the subtenons space there is presence of low reflective X. But in case of posterior scleritis, T sign is there, but it is clear. And we can also clinically correlate. In case of panophthalmitis, there is presence of hyperpine or exudate or vitreous cells in the anterior chamber. So by picture, both the ocular cysticercosis and dislocated lens looks like a same. So we can see there is a scolex sucker in the sucker surrounded by a cyst. So surrounded by a cyst. So in second case also, there is high reflective because looks like a scolex. But when we do a scan in supine position, both seems to be same. But while doing in erect position, if there is dislocated lens, then it moves inferiorly, and always live cyst does not cause any inflammatory sign. So if there is presence of any inflammation, presence of cells, that means that there is cyst, dead cyst. So now coming to the tumor. So in case of choroidal melanoma and choroidal hemangioma, there is a color button like appearance. But in case of choroidal melanoma, there is acoustic hollowing. But in choroidal hemangioma, there is no hollowing. In case of melanocytoma, there is high reflective mass-like echoes at the optic nerve end. Now, in case of choroidal melanoma and choroidal metastasis, both cases, mass looks like mushroom-shaped or color button-like appearance. But in case of choroidal melanoma, contour is regular. And in case of choroidal metastasis, contour is irregular. So we can find high reflective mass with calcification in case of retinoblastoma. And retinoblastoma we can find there is a leukocoria in the anterior segment. Sometimes choroidal osteoma and thysis bulbi looks like same. So in the both cases there is a plaque-like calcification. But in thysis bulbi, there is disfigure eye, and hypotonia is there. But in choroidal osteoma, there is a plague-like calcification, and it is generally happen in case of female in 2 to second and third decade. And if the lesion is away from the optic disc, nerve, then we can find double optic nerve-like appearance. So this is the typical feature of choroidal osteoma. Now coming to congenital anomalies. So coloboma is in case of coloboma, we can see there is excavation with sharp margin. So we can see here there is no smooth margin, there is sharp margin, and this is the excavation at optic disc. Sometimes we have to find whether cyst is there or not in case of choroid, because if there is detached intracalary membrane, then there will be presence of cyst. So we can see here there is a detached intracalary membrane, and we can find this scleral fistula. And often we mistaken to diagnose whether this is retinal detachment or something else. So we can find in case of coloboma membrane-like structure that is not tardy. This is detached intracalary membrane, but there in intracalary membrane there is chances of being retinal breaks at that point. So now coming to the choroidal coloboma and posterior staphyloma. So in both cases there is a excavation, but in choroidal coloboma, there is excavation with sharp margin. In posterior staphyloma, there is excavation with smooth margin. Now microphthalmos and nanophthalmos. So everybody, I think, heard about the nanocar, because what happens in what is the feature of nanocar? So every structure, every body parts of nanocar is small except pilot or driver, So similarly in case of nanophthalmos, every structure of eyeball is small except lens. In lens, it is relatively normal in size, but and in nanophthalmos there is gross thickening of retinal choroidal complex, and sometime in nanophthalmos there is association of choroidal detachment. In case of microphthalmos, there is excavation. In case of microphthalmos, all the structures are small and generally associated with structural deformities like coloboma. These are the scans of three different cases. But by scan, by a scan only, we get confused because all looks like similar. So in case of PSPV or PFB, persistent fetal vasculature, there is band-like membranic echoes extending from the disc to the posterior surface of the lens. And in vitreous incarceration, this is not the membrane. Actually, this is happen after the penetrating trauma. So this is the blood. This is the blood in the tract in the track of penetration. So this membrane is nothing but blood from the other part of the eyeball. And in case of ROP, we get a closed funnel shaped fibrous band and there is history of low birth weight. Now surgical, Kapil. Hello.
Yes, sir, yes. It's audible.
अल्छी लागेको छैन नि?
छैन sir. It's good. Okay, sir. Making the interactive, so I guess there is one question. So, what clinical information would be important in your diagnosis?
Sorry.
What clinical information what clinical information would be important in your diagnosis?
So this is I have already told. This is the clinical correlation. So suppose in vitreous cavity we see multiple low reflective dot like echoes in the vitreous, and then we get confused whether is it vitreous cells or vitreous hemorrhage. So first we have to see the anterior segment. So in the anterior chamber, whether there is presence of reaction or hypopyon or rigidity is there. If it is present, then then the echoes goes to the vitreous cells. But anterior segment, cornea is not hazy, cornea is cornea is clear, and there is no inflammatory sign in the anterior chamber. Then there will be the probable chances of vitreous hemorrhage or something like vitreous degeneration. I think it is
Yes,
clear.
yes.
I think.
Okay, sir. So on posterior scleritis, what type of B scan shows?
What type of B scan?
B scan.
Shows.
Yes, sir. B scan. Yes.
Okay. So in posterior scleritis, you can do a transverse scan. Transverse scan. So in posterior scleritis, there is a T sign. There is T sign, but in the subretinal capsule, there is no infiltration. So it is very eco-free, tenuous capsule is there. And in anterior segment, there is very little cell or anterior chamber may be quiet. Hello.
Okay, sir. So we'll be heading with the presentation, and if anything, and we'll be discussed on the second round. Sir.
Okay.
Sir, video आ छैन.
So
Yes, sir. We switch off the video because for better quality of sound. So it will be better if we switch off the video. Thank you. Sir, we can proceed to the presentation, sir.
okay. Should I start? Kapil?
Sure, sir.
Yes, sir. Yes.
Hello, Kapil.
Yes, sir. We can continue the presentation, sir.
Okay. So in case of silicon wire field globe, the eyeball is elongated. Okay. So now there is a question. There is question to all the students. in case of silicon oil, why globe is elongated? And second question is that if globe is elongated, then there will be refractive error will be myopia. But in case of silicon oil, there is hyperopia. Why? Kapil?
Okay, sir. Okay. Is there
Chat
any
box
problem,
में
sir?
comment गर्दा नि हुन्छ? No.
Okay, sir.
So I am asking a question. In case of silicon oil,
Okay.
in case of silicon oil, elongated eyeball is there. Okay. So
Yes, sir.
why eyeball is elongated? And if eyeball is elongated, then there will be myopia. But in case of silicon oil, there is hyperopia.
Okay.
Any comments, Kapil? Any
Sir,
comments from students?
Reflective
Yes,
index
Pooja. Yes.
isn't it?
Yes, Pooja. Okay.
Sir, index will be changes, so refractive index.
Okay.
Because of the curvature of the silicon oil, the hyperopia is induced.
Okay.
Yeah, that's true.
Okay. Thank you. In case of silicon oil, the velocity of silicon oil is less than that of the velocity in the aqueous. So sound travels slowly. So it appears elongated, and in elongation there is silicon.
Excuse me,
The
sir.
density of yes.
Sir, how sound is related to the velocity? Actually, the light travels through the eyes. How sound travels?
No, this is a picture of ultrasound. Okay, this is a sound. There is a transmission of sound. There is a transmission of sound here. That's why it is elongated. Okay, but in case of refractive error, reason is other. Okay, so the refractive index of silicon oil is less than that of the aqueous. So because of less refractive index, the parallel rays coming from the infinitive focus behind the retina. That's why hyperopia is there, but elongation is due to the less velocity. Did you get?
Yes, sir. Yes.
Okay. So okay. Now coming to the silicon oil, emulsified silicon oil, steroid halosis, vitreous hemorrhage, and vitreous cells. So first, I would like to discuss about emulsified silicon oil and steroid halosis. So by the scan, both looks like similar, medium size, high reflective equals in the vitreous cavity. But in case of steroid halosis, there is echo-free space. You can see here there is echo-free space just in front of the retina. But in silicon oil, we can see high reflective echoes spread everywhere, and we can do other scan also. If we do scan for superior quadrant, then in silicon oil, in case of silicon oil, echoes increases, but in steroid halosis, echoes remains same. Similarly, in this picture, there are lots of low reflective echoes noted in the vitreous cavity. So in the both the pictures looks like same. So generally fresh we get confused in fresh vitreous hemorrhage and vitreous cell. So first in first picture which vitreous hemorrhage, in vitreous hemorrhage what happens, we have to measure the choroidal thickening. So if choroidal thickening is normal, then it is vitreous hemorrhage, and and if choroidal thickening is more than the normal, then there will be vitreous cells. And generally choroidal normal range of choroidal thickness is 1.4 to 1.6. So if there is more thickening, then it goes to vitreous cells, and if the thickness is it is the vitreous hemorrhage. And also we can do one scan in inferior quadrant. Okay, so if in inferior quadrant echoes increases, then this is vitreous hemorrhage, and if echoes remains same, then it is vitreous cells. And we have to also correlate with the clinical findings. So we have to measure choroidal thickness just inferior to the optic nerve, and gain should be at 77 decibel if your B scan machine is of 100 decibel. We sometimes we get confused with the scleral buckle to the RD. So in case of a scleral buckle, there is high reflective band-like structure with the orbital shadowing, and in case of RD, there is no orbital shadowing. So in these pictures, we can see there are folds and buckles looks like same, but in case in scleral folds, there will be presence of hypotony, because scleral fold happens after the penetrating trauma. And we can also found in case of the scleral fold there is a cross thickening of the retinal choroidal complex. And now coming to intraocular air and PCIOL reverberation. So both are the reverberation. So if there is reverberation due to the intraocular air, then echoes float in the opposite direction. Against movement is there, but in case of posterior chamber IOL, there will be the with movement. Now coming to the optic nerve disorder. So normal diameter of retrobulbar optic nerve is 2.2 to 3.3 mm, and difference between both the optic nerves is more than 0.5 mm. That means there is some pathology of optic nerve. So to differentiate it, whether this is pseudo tumor or actual tumor, so 30-degree test is performed. So 30 test, 30 in this picture we can see there is increased gross thickening of optic nerve, and then there is a gross thickening of optic nerve. So if you rotate the probe 30-degree and see the thickness of optic nerve, if the thickness of optic nerves is decreased, then this is the pseudo tumor, and if thickness remains same, then it is the actual tumor. So in case of papilledema, there is we can found there is a high elevation at the optic nerve head with typical sign, that is crescent sign, drawn out sign we can found in case of papilledema. You can see here there is marked difference between both the eyes of optic nerve of both the eyes. So if there is marked difference, then there will be presence of some pathology or some tumors like that. So sometimes we get confused in to differentiate whether this is papilledema or optic buried drusen. Then B scan is suggested. In B scan, we can see there is high echoes and which persist at very low gain also. So if high refractive echoes is there and it persists at the low gain, then it suggests that this is a buried optic disc drusen. So in case of mature cataract, sometimes we have to explain to the patient about the prognosis. So that time we have to see the gross cupping in case of mature cataract. So if cupping is more than 0.5, then we can find there is excavation at the optic disc. So thank you for kind cooperation. Hello, Kapil. Hello.
Yes, sir.
Kapil.
Yes, sir. Yes, sir. Yes.
Okay.
So, okay, thank you so much once again. Thank you so much, sir, for such a wonderful presentation. I guess this much of collecting the cases and studying on the single lecture is, we feel so privileged to you. And I want to go to some question that you have raised. Let me check some of the question. Okay. So there is a one question: how to interpret intrinsic tumor vascularity?
Sorry.
Intrinsic tumor, yes, sir. How to interpret the intrinsic tumor vascularity? I don't know. So,
Yes, Kapil.
yes, sir. Intrinsic tumor vascularity, sir. Is there any cases? Yeah.
Vasculitis. In case of,
I guess.
sorry, in
Yes,
case
sir.
of.
So I guess it is a special type of case. So yes, if there is a tumor or with a vascularization, how to identify it?
No.
Okay. Okay. In case of tumor, there is shadowing, and a high refractive shadowing is there.
Yes.
But vasculitis. But vasculitis.
No, actually, I think the question. Hello, Amit.
Hello.
Okay.
Hello, sir.
Yes,
This is
sir.
Priya
Yes,
Jana
Ajay.
from Hyderabad.
No, I think Ananta Podel.
Okay.
Hello.
Hello.
Yes, Ajit sir. Yes. Yes. Ajit sir. Yes. You can go with question. Yes.
I think the question is asking how do you
Okay.
क्वेसनले के सोधा रहेछ भने भ्यास्कुलरिटी कसरी थाहा हुन्छ रे ट्युमरको त्यो ट्युमरको भ्यास्कुलरिटी कसरी थाहा पाउँछौ रे
Hello,
that's
sir.
he is asking I think.
Can you just briefly explain how to perform 30-degree B scan? Can you explain the procedure, please?
Okay. Thank you, Priya.
No.
First we do axial scan. Okay, to the axial scan, axial and longitudinal scan, and then we have to tilt the probe 30 degree. Okay.
Okay. But the marker will be on the nasal side.
Okay, marker. See. The always marker. If always marker is superiorly in case of nasal and temporal, and in case of superior and inferior, should be nasally. Marker should be superior.
But in case of 30-degree B scan, when we are tilting the probe to 30 degree, the marker will be on the nasal side, right? Hello?
Marker will be superiorly. Marker will be superiorly. This is transverse scan. Marker will be superiorly.
Mm-hmm.
Sorry for interruption. When you want to do the 30-degree B scan, so first you perform the axial scan. Okay.
Okay. Yes.
After that, you say the patient look on the towards the probe side. So when the patient is looking on the probe, then the eye automatically turn. So this is the kinetic procedure, and eye automatically shifted toward the 30-degree angle. So we can actually visualize the angulation of optic nerve head and optic nerve sheathing.
Okay.
This is the main procedure of the 30-degree B scan.
Okay. Last question. Suppose when I'm doing the 30-degree B scan of right eye, the patient will look towards the probe through the left eye, or I have a confusion there.
No. When same eye and when you're doing the axial scan, so your the patient's eye is closed.
Yeah, yeah.
Okay,
So,
but the patient is conscious. Okay, so you toward the patient, you look on the probe side, so you can
okay.
so so patients can see the other eye. Okay, so it can be
Okay.
manageable. So this is the main
Okay.
procedure because you have no idea about the measurement in the degree.
Right.
So this is the main technique.
Excuse me. Thank you, sir.
Yeah.
Any comment from other side? Because Dai is there, and Ajit Dai, Hunamza. Hello.
हेलो अँ छु ठिक छ
Ajit Dai, any comment? Any comment? Any comment regarding
ठिकै छ
the 30
त्यो
degree test? Okay.
नो इट्स फाइन
Okay, so I guess okay. So there is another question, sir. So I guess we have answered this question.
Okay.
Okay, sir. Can you go further again this intrinsic tumor vascularity question, or I may proceed with another question, sir?
Yes. Yeah,
Okay.
yes.
So, okay, is there any difference between the sweeping probe over the lid and over the sclera?
Sorry. Can you repeat the question?
Yes, sir. Yes, sir. Is there any difference between if we sweep the probes over the sclera or over the sclera, over the eyelid or over the sclera?
Okay. Okay. See. Suppose suppose if we are doing paraocular scan in case of orbital scan, then we have to place the probe at the lid, because to see the lid pathology we have to place the probe at the same side, at the site of area of interest. Suppose lid abscess is present in the upper lid, then we have to place the probe at upper lid, not inferior quadrant, inferior lid.
Okay, okay. So there is the answer from the Ashish sir. So he's saying that if there is a want to see the vasculitis, there will be the twinkling like effect you can see within the tumor, which indicate the blood flow. Okay, sir. And
For
okay,
that,
if the,
I'm not very much sure. I'm not very much, but I think Doppler technique will be better method to differentiate whether the vasculitis is coming from tumor or not. So, any comment from Ajita or Vikas Samal? What is there, Vikas Samal?
Yeah, one. Actually, when we do BA scan, we are not that much static. Our hands move, so it's very difficult to comment on the vascularity it's moving or not. So, as Amit rightly said, this eco-based technique, Doppler technique, is the best suited. But still, in some book, we find that by doing this static BA scan, we can find there is vascularity or not. Especially in choroidal melanoma, I think they have written in books. I find so.
okay, that's a great.
Hello.
Okay, thank you.
Yes. Okay, so can you please say something about the ocular dynamic USC?
Ocular dynamic is that is kinetic scan is there. So I think do you want to know about kinetic scan?
I guess yes, sir. There is one question like about the ocular dynamic USC.
Okay. In kinetic scan, then probe is fixed. Okay, so probe is fixed, and patient is asked to move his or her eyes here and there. So and we have to see the membranic echoes at whether it is free after the movement or restricting after the movement. So this is basically to differentiate RD from the PVD. So if it is free, then it is PVD, and if it is restricted, then it is RD.
Okay,
Am
sir. Thank
I?
you. Yes,
I
yes, sir.
think
You are clear. Okay. Yes, you
okay.
are clear. So, so there is another question from the Nikita. So, sir, how can we differentiate between the exudative ARD and retinosis by pressing the finger with the finger, as you say? Can you please explain it again?
Okay. Just do a scan and hold the probe. Okay, and press the eyeball with the finger and see the structure of the elevation. Okay, whether it is whether shape is changing or not. If shape changes, that means there is exudative RD. If not changing, that means this is the retinocysis. Or you can do you can do you can do a scan in erect position also. If in supine position there is a elevation, but if you do scan the erect position, then due to the gravity, fluid goes down.
Okay, okay, sir, it is clear. So, Juno ji wants to, sir, can you please once again talk about the silicon oil? So, sir, I will be putting this video on YouTube. So, we'll be discuss. You can review yourself. Before that, sir, can you please shortly describe about the silicon oil?
Okay. So in silicon oil we get elongated eyeball. Okay, so why elongation is there? Because velocity of silicon oil is less than that of the air and aqueous. So it takes more time to sound takes more time to travel through it. So that's why it is elongated. And in elongation, in eyeball is elongated, but refractive error is in plus hyperopia, because density diffractive index of silicon oil is less than that of the water. So, when the parallel rays of light coming from infinitive focus behind the retina. So, and in silicon oil, we have to take we have to see the all the quadrants, because and never miss the superior and inferior quadrant, because property of silicon oil is because of the less density, it moves upward, so there will be chances of retinal detachment in the inferior quadrant. So we have to never miss the inferior quadrant. And why superior quadrant? To see the whether silicon oil is emulsification start or not, or so if we do a scan in the superior quadrant, then we can find more echoes in the superior quadrant. So this means that there is emulsification of silicon oil. Juno?
Hello, hello.
Yes, sir, Ajit sir, yes.
Yes, yes. Yes, Ajit.
Just I want to add one thing. What I feel, as Amit said, there's velocity of sound in the silicon oil is it's right. It's 932 around, I think. If it is in 1532 in phakic
Yes,
lens,
yes,
it's 932 in something. Yeah, that's good. But just I'm disagreeing with other point of Amit. What I feel, the silicon oil refractive index is more than vitreous. I think it's around 1.40 refractive index. But why it is hyperopic? What I feel that due to higher refractive index than that of aqueous, and our lens being biconvex, so the posterior lens system behaves like a concave lens, and it will behave like a negative lens, and that's why you need some +3 to +6 diopter power in front. So, due to the refractive index being higher of silicon oil, it will act like a negative lens, concave lens. That's why I think you need +3 to +6 diopter hyperopia power in front. I think this is a logical reason why your patient is hyperopic with vitreous. What others say, I don't know, but what I feel, this is the logical answer.
Okay,
Okay,
thank you, Ajit bhai.
that's great. So, sir, can we talk a little bit about the contraindication? Like where we can do the USC? Yes, we very much familiar with the OGI and ocular trauma, but beside this thing, is there any contraindication for doing the USC?
Yes, Kapil, yes. In case of OGI, we generally postpone the B scan. Okay, so we generally do not. I suggest not to do not to do the scan, but not to do the scan. But if you are very much expert, then you can do, but very gently, because sometimes by pressing a bit aqueous or vitreous comes out. So if you are not very much sure, then do not do the B scan in case of OGI. You can do after the repair.
Okay, sir. Actually, my question is there any other contraindication for USC?
uh, so in case of OGI, we do not suggest to the do B scan.
Okay, sir. Okay. So, what is there any special things like in the children that we can go with the USC so easily? So, is there any advice to if we are doing the USC on children or in a pediatric population?
Okay, in pediatric cases, while doing a scan, we have to comment about globe size also, because we have to in case of cataract, we have to put the lens. So sometimes um, uh, we cannot do IOL master in case of a mature cataract in the child, or child is not very much cooperative. So we have to comment about the globe size. So it gives the gross idea about the actual length. And if you do a scan in under anesthesia, then it will be better.
Okay, fine, sir. So, if anybody has the question, please unmute yourself. You can go for the question. So, if anybody have the question, please you can unmute and go for the question. We'll be waiting for 1 minute, and I guess we answer the most of the queries. Okay, sir. Thank you so much, sir. Such a wonderful presentation, and we are so much thankful for you, and we are all happy to see you on our platform. So, before that, if you have any good notes or you want to give some comments to our platform for betterment, we will be waiting for the 1 minute, and we'll in the presentations.
So thank you, Kapil. Thank you, Kapil, for giving me opportunity. So do B scan, start B scan. So so nothing is impossible. So you can do, and you can see the different cases, and by doing B scan again, you will be familiar with the lots of the cases, and that will be very fruitful in your future. So please do B scan. If anybody has any query, please you can mail me, or you can call me. And if I am not giving I'm not able to give the answer, then I will beg to the other experts, and assure at last assure I will give the answer to the all the questions. Okay, thank you.
Thank you, sir. Okay, before ending the today's session, I'd like to again express my sincere gratitude towards the presenter, Mr. Amit sir, and all the attendees. And also, I like to appreciate all the helping hands for the iTux program. Herewith, I am ending the today's session, requesting all of you, please provide your valuable feedbacks and review. Thank you so much. Stay safe. Stay at home. Thank you. Thank you, sir. Have a good day.
Thank you, Kapil.